Sharma. She is consultant audiologist and
तो voice to आना है लेकिन
consultant audiologist. Okay, paisene. She is consultant audiologist and speech language pathologist at Pratiksha Hospital, and moderator of the session is Dr. A.K. Biswas sir. He is at present working as senior lecturer, selection grade in Department of ENT, GMCS. Correct. Over to you, Biswas sir.
Good evening. Good evening to everybody. Today's talk Manashi is going to give. Manashi doesn't need an introduction. Already she has been introduced. What I wanted to tell a few things. If you look at the chronology, in 80s when the implant was started, it was started with the unilateral implantation in adult with bilateral severe to profound hearing loss. Next step they took is unilateral implantation in children with bilateral severe to profound hearing loss. Then the next chronology was unilateral implantation with associated disabilities. And after that, they moved to bilateral implantation for the recipient. And finally, now implantation with marked residual hearing. So that is the basic chronology that has been started with implantation. Now, if you look at the today's expanded criteria, it is children and adults born with moderately severe to profound hearing loss. Then you have, if the aided speech discrimination score is less than 50%, and in lexicon test in children, if it is less than 30%, these children should be implanted. And there is no, the child should not, the child or adult, there is no benefit from the hearing aids. These are the recent criteria. And if you look at the age, ADIP has given age criteria of 1.5 years to 5 years for children. And for post-lingual, it is till 18 years. And if you look at the CG guidelines, they have given it to 1 to 17 years. And less than 1 year and more than 17 years, that is team has to decide. And for the adult, there is no age limit they have given. So looking at these trends, so Manashi will let us know exactly how, what are the changes that has been taken. Thank you. Over to Manashi.
Thank you, sir. Is my slide visible?
Yeah, it's visible now.
And I'm audible? Okay.
Yeah, it's audible.
Thank you, sir. Good evening, everyone. And thank you for joining us this Monday evening after a hectic day at work. And today I'll be talking about recent developments in evaluating cochlear implant candidacy. The eligibility criteria for cochlear implantation are constantly evolving due to the continuous progress in cochlear implant technology, more and more knowledge about cochlear implant fitting, and the possibility to preserve residual hearing. Before we go deeper into the topic, slides are not moving. Sorry for that.
Click on the screen once and then you'll be able to move them.
Yeah. So why are we talking about candidacy today? Because hearing loss is prevalent and it is undertreated. And here we can see that there are around more than 460 million people worldwide with a disabling hearing loss, out of which 34 million are children. And we can see that there's a large number of individuals in want of a cochlear or a bone conduction implant, while only a few of them are actually using it. And this is the statistics given by WHO 2017. And the impact of untreated hearing loss on an individual can be seen here, and the impact that it has on the economy of a country. The possible benefits from cochlear implantation in the pediatric population There's better speech perception and quieter noise, leading to better language development, improved quality of life, leading to better socialization skills among the peer group, and educational benefits in terms of reading and writing skills. In adults, better speech perception and quiet and noise is seen, and they recover from depression, embarrassment, frustration, and isolation. There's an improved quality of life, making them more independent, and there's improved socialization. There's also more efficiency at work, and they become cognitively alert. They also get to use the telephone better. Now let us understand who needs a cochlear implant and why a cochlear implant. Now this is the cross-section of healthy cochlea with outer hair cells and inner hair cells. But when an individual has severe to profound hearing loss, this is what we see: damaged outer and inner hair cells. Now these regions are called dead regions, and these are associated with severe to profound hearing loss. Now in a day-to-day practice, it is difficult for us to identify dead regions. So many studies, including the study done by Vinay and Moore in 2007, say that if there's a threshold more than 70 dB at any of the frequencies, it's an indicative of dead region. So in such cases, if we try to amplify a child with the highest of the amplification and the best of the amplification devices, there are no hair cells to transmit the signal to the auditory nerve. So the solution in such cases is to directly stimulate the auditory nerve. So if we try to amplify such an individual, we see limited speech recognition benefit from hearing aids, resulting in its non-usage. There's also high frequency amplification due to feedback and distortion. They also complain of loudness discomfort and ear mole occlusion because the ear moles are really tight, which leads to frequent follow-up sessions and making them unhappy and frustrated candidates. Now, to understand the age at which a child should be implanted, let us look at it through the lenses of the Lockheed study. The study was done by Ching and Dillon at the National Acoustics Laboratory, and it emphasized the effectiveness of early intervention. Here on the x-axis, we can see the ages at which the device activation was done, and on the y-axis, we have the global language scores. So here we see that later a child was implanted, poorer are the global language scores. This study also emphasized that kids implanted prior to 12 months of age are doing much better than kids implanted post 12 months of age. They also studied the cochlear implant predictors, and they reported that lower the age at which the first hearing aid fitting was done, lower the age of cochlear implant activation, the 4-frequency average hearing loss, higher cognitive ability, higher maternal education, and if the child is using an oral communication mode, these are positive predictor of cochlear implantation. The only negative variable they found was additional disabilities, but they've also given a disclaimer that they should not be viewed as a reason to not pursue implantation for a child. So to summarize, the right age for implantation, 0 to 3 years is the optimal age for implantation because during this period, the child gets to use the benefits of the critical age period. Post 3 years of age, a child would get suitable hearing from cochlear implantation, but will have limited spoken language output. Beyond 6 years of age, a child will get very, very limited output from the cochlear implantation. But if the child has been hearing an amplification device for quite some time and getting some benefit out of it, we can still consider implanting that child. Also implanting children with progressive hearing loss and acquired hearing loss at this age is possible. Now let us look at the current criteria for cochlear implantation. The candidacy for cochlear implantation is constantly evolving, with unilaterally implanting adults with bilateral severe to profound sensorineural hearing loss to unilaterally implanting children with bilateral severe to profound sensorineural hearing loss. And then we moved on to implanting recipients with associated disabilities so that if these individuals overcome their hearing problem, they can have a better chance at having a better quality of life. And then we went to bilateral implant both adults and children, which became a standard of care. And then we moved on to implanting recipients with residual hearing. And in 2019, FDA approved implanting adults and children with single-sided deafness, having a deafness duration less than 10 years. And children above the age of 5 years qualify for cochlear implantation with single-sided deafness. Now, there are various guidelines globally given by different nations of the world. And so let us quickly go through the guidelines. The FDA guideline given by USA says that any individual having 18 years or older, having a bilateral moderate to profound sensory neural hearing loss, having limited benefit from amplification, defined by preoperative test scores of less than equal to 50% sentence recognition in the year to be implanted, and less than equal to 60% in the opposite ear or binaurally, qualify for cochlear implantation. Children in the age range of 2 to 17 years, having bilateral severe to profound sensory neural hearing loss, having limited benefit from binaural amplification, and having scores less than equal to 30% in the multisyllabic lexical neighborhood test or lexical neighborhood test, qualify for implantation. In 2020, FDA lowered the age for implantation in children to 9 months. And so children in the age range of 9 to 24 months, having bilateral profound sensory neural hearing loss and having limited benefit from binaural amplification, qualify for cochlear implantation. So these are the guidelines laid down by TG Australia. And this is the NICE guideline given by UK. And coming back to India, we have 2 sets of guidelines, the ADAP guideline and the CG guideline. While implanting children under the ADAP scheme, we'll have to follow the ADAP guideline. So an individual with prelingual deafness should be in the age range of 1 to 5 years, and postlingually has to be an individual up to 18 years of age is suitable for cochlear implantation. Both under ADAP and CG, the individual should have bilateral severe to profound sensory neural hearing loss to qualify for cochlear implantation. Under ADAP, the individual should have a period of 3 to 6 months of hearing aid usage and having little or no benefit from the hearing aids and limited speech comprehension scores. And these individuals qualify for cochlear implantation. So to summarize today's expanded criteria for cochlear implant candidature, children born with a moderately severe to profound sensory neural hearing loss, adults or children who acquire a moderately severe to profound sensory neural hearing loss qualify for cochlear implantation. We also look at the speech perception scores, and which varies from country to country and clinic to clinic, and aided speech identification scores less than equal to 50%, and an individual having no benefit from hearing aids are candidates for cochlear implantation. A study by Zwolon et al. In 2020 say that anybody who has a sensory neural hearing loss greater than an average of 60 dB and cannot understand more than 60% of words in their better ear should be investigated for a cochlear implant candidacy. Now, in a clinical practice, we come across individuals having an audiological profile which do not fit into any of the guidelines that we just discussed. So in such cases, the decision to get the child implanted or not implanted is based upon the motivation of the parents and also the team's decision. So the study by Lisa et al. In 2021 December says that using evidence-based practice, centers have been providing off-label implantation for children who fall outside of current FDA criteria, including children with more residual hearing, children with single-sided deafness younger than 5 years, and infants with bilateral profound loss younger than 9 months. So in such cases, if the parents give the concept to get the child implanted, the team can go ahead with the cochlear implantation. Now let us look at some case studies. A 3-year-old RV came to a clinic with her parents, and the parents complained that RV has inconsistent response to loud name call and environmental sounds. She understands commands when accompanied by pointing and gestures and uses pointing and gesturing to express her wants and needs. No significant prenatal, natal, or postnatal history was reported. No family history of hearing loss or any other disability was reported. She has age-appropriate motor milestones and cognitive skills. She wants to play with a peer group, but finds it difficult to communicate, leading to no friends, which makes her unhappy. This is the audiological profile of RV, revealing normal middle ear function with absent acoustic reflexes. OEEs were bilaterally refer, and BERA and condition audiometry showed bilateral severe to profound hearing loss. Radiological evaluation suggested no abnormalities, and she has been using a superpower hearing aid bilaterally and undergoing AVT for past 1 month. So this is the aided audiogram that we could obtain after 1 month of AVT. So this is the right aided audiogram, and this is the left aided audiogram. And in both the audiograms, we can see that at the lower frequencies, the aided thresholds are at the lower spectrum of the speech banana, whereas in the mid frequency and high frequencies, the aided thresholds are much below the speech banana, suggesting that she is getting very, very limited benefit from the amplification devices. Now, RV is a classical candidate for cochlear implantation. If that be so, the question is, why wasn't she fitted with hearing aids? So for children who are preparing for cochlear implantation, we do have a hearing aid loaner program in our center, which gives loaner hearing aids on a loan basis till the child gets implanted. The rationale behind giving the hearing aid is to get the child adapted to wearing a device on the ear, and secondly, to at least provide some hearing stimulation so that the child gets into the habit of listening. The second case is a 3-year, 2-month-old child, Gianna, and her parents complained of speech and language delay. No hearing complaint was reported. She has difficulty following simple verbal commands, and she uses pointing to express her needs and wants. There was a prenatal history of gestational diabetes. She is a term baby with a birth weight of 2.4 kg. Immediate cry was present, and she had jaundice, and she underwent phototherapy for 24 hours. She also has fleeting eye contact, inadequate attention span, and inadequate sitting tolerance. She has age-appropriate motor milestones, and her social communications skills are poor. Now, this is the audiological profile of Gianna, revealing normal middle ear function with absent reflexes. OAEs were bilaterally refer. The right ear showed moderately severe hearing loss, and left ear moderate hearing loss was found. Radiological evaluation suggested no abnormality, and she is using high-power hearing aids bilaterally and undergoing AVT sessions since last 2 months. So the aided audiogram that we see here was obtained after 2 months of AVT. So if you look at the right aided audiogram, we can see that the thresholds are within the speech banana, and at 4 kilohertz, it's out of the speech spectrum. But still, Gianna is still missing out on some speech sounds. In the left aided audiogram, it's towards the upper spectrum of the speech banana, but not at the upper string ping. So still, she is missing out on some speech sounds. So presently, Gianna responds to most of the environmental sounds, even when made from another room. She can detect, discriminate all the link 6 sounds, and identification of a, oo, are present, and discrimination of a few learning to listen sounds are present, like hobo versus quack quack versus meow. The aided speech detection threshold for the right ear is 50 dBHL, and for the left ear is 40 dBHL. Now the question here is, should Gianna continue using hearing aids bilaterally? Will that be sufficient for her to give appropriate spoken language output? Or should we go ahead with the cochlear implantation? Or should we wait and give her some more time with more training to see if she does better with the hearing aids? Divyansh is 2 years, 3 months old, and his parents complained of delayed speech and language development. He communicates by showing irritability and by crying when hungry or in distress. He babbles occasionally, and no hearing problem was reported. He does not respond to his name call and finds it difficult to follow simple verbal requests like "give me." There was no significant prenatal history, and he was a preterm baby with a low birth weight of 2.1 kg. He has a history of NICU admission for 48 hours. He has delayed motor milestones, fleeting eye contact, and inadequate attention. MRI brain revealed no abnormalities. And this is the audiological profile of Divyansh, which revealed normal middle ear function with reflexes present in the right ear and absent in the left ear. OE in the right ear was pass, and in the left ear was refer. And BERA revealed normal hearing sensitivity in the right ear and severe to profound hearing loss in the left ear. Divyansh has been using a superpower hearing aid in the left ear and undergoing AVT since past 1 month. Presently, he can detect some environmental sounds. He also localizes sound source and smiles when spoken to from the front. His eye contact and attention span has increased. So the next question is, are Gianna and Divyansh candidates for cochlear implantation? Let us quickly go through some studies in support of implanting candidates with moderate to severe hearing loss. For patients with the hearing loss less than equal to 80 dBHL, cochlear implantation should be considered if hearing aid use results in insufficient speech recognition. Improved speech recognition through cochlear implantation was observed in about 98% of the cases, with a median word recognition score of 70% 6 months post-implantation. Now, the study by Kratep et al. In 2015 showed that cochlear implants provide better results compared with hearing aids in children with residual hearing. Lisa et al. Explored the possibility of electric-acoustic stimulation in children, and they said that cochlear implantation with electric-acoustic stimulation fitting is a viable option for children with hearing aids who have residual hearing but have insufficient access to high-frequency sounds and poor speech perception. Studies in support of implanting individuals with single-sided deafness show that early data are promising that cochlear implantation for single-sided deafness can help to restore binaural functionality, improve quality of life, and may facilitate reversal of neuroplasticity related to auditory deprivation in the pediatric population. Also, another study by Calvin et al. In 2019 suggests cochlear implantation for individuals with single-sided deafness. The obvious goal of careful selection of cochlear implant patients is to never have a single patient perform more poorly with a cochlear implant than they did with their hearing aids. Thank you, and the presentation is open for discussion.
Stop sharing.
Then Mansi, you can
Yes.
stop sharing your presentation.
Okay, yes.
Vishwas sir.
Hello,
Yeah.
can you listen?
Yes, sir. Yes, sir.
Yeah, it's open for discussion.
Chat box by SB Fukan sir. Mansi.
Nanjana ma'am, you can start from the question. What about the prelingual adult criteria, Mansi? By Fukan sir.
Mansi,
Yes, ma'am, I can hear you.
what about prelingual adult criteria SB Fukan sir has asked?
We haven't come across any, if we see if the adult criteria of the FDA also, individuals, they haven't mentioned about any prelingual or postlingual. They haven't differentiated. They've just mentioned that individual 18 years or older having bilateral moderate to profound sensory neural hearing loss qualify for cochlear implantation.
No, that part has not been covered. They have not talked about
Prelingual adults.
speech and language thing. They have talked about only hearing loss. So anybody more than 18 years and no age limit, they can go with implantation. Even the CG has the same guideline. So it depends on the team to decide.
So that means that this what is prelingual adult?
An adult who has hearing loss since birth.
Since birth,
So,
but he is 18 plus.
Yes. So before he develops language, prelingual is before the individual develops language.
So what is the age? What is the age?
If the individual develops sign language, that is also a language.
Okay. And that's why I'm asking, sir, what is the, how will you define the prelingual adult? Who are the prelingual adult? Very specifically.
Prelingual, what I understand is speech and language. There is a lack of speech and language stimulation. Speech stimulation. Okay, but language, if the individual learns sign language, then he has language.
Only language, sir.
Yes,
that's also language, sir. Then what is a prelingual adult then? Who are the candidates then?
So technically, yes, if a person has sign language, it is also a language, but typically when wherever prelingually deafened or prelingual adults with hearing loss, they refer to individuals who are adults now, but who are living with a hearing loss which was acquired before language development. And this is typically before 2.5 years of age. But again, even if a person develops, an adult who's above 18 years of age who developed hearing loss maybe at 3 or 4 years of age, even they will not have any verbal or if they may not have any functional verbal language to communicate. So they will be considered as prelingually deafened adults. And in those cases, like Mansi and Viswas, all of them said, there are no fixed criterias mentioned. There are no medical or as such contraindications, but the benefit is definitely going to be limited in terms of language development. So depending on the expectation of the family, depending on the expectation of the individual, with proper counseling, they can go ahead, considering all the other factors.
Yeah, they can go ahead, and depends on the team. Team. If the team thinks that it's right and the counseling is appropriate and the individual understands, then they can go ahead. But because the CJ has said it depends on the team, no? Team has to decide.
Mansi, may I request you to kindly show the unaided audiogram of the second case?
Yeah.
Like the pure tone audiogram.
Just give me a second. My actually screen went to the, just give me a second. You wanted to see the audiogram of the second case, the aided audiogram?
Not the
Or
aided
you want to see
audiogram.
the
pure
you want
tone
to see the pure tone audiogram? Okay.
and the aided one, aided audiogram. Okay.
So ideally, if we look at this aided audiogram, we expect her to develop a few more things, but we're still stuck with the discrimination of the LTL sounds. Maybe she would be needing some more time to develop it, or maybe we should be giving her some more time, and then we can take the decision.
How many months therapy has been given?
2 months, sir. 2 months.
2 months. Yeah, you should give more time. I hope.
And more importantly, like it depends on the aided audiogram. If this is the aided audiogram and this is the final setting, the hearing aid is at the maximum, most optimum setting. And yet the aided responses, especially I would say for the right ear, it's very clear that the child is only getting partial benefit. She's missing out on most of the sounds in normal conversational voice. Then
Yes, that is what.
yeah, that is, I think that kind of gives us a direction to think that, at least for the right year, she may be just a candidate for CI.
Yeah, so what I was planning is she presents in the maximum gain. So after a month, so then she'll be completing 3 months. I'm planning to get another aided audiogram done to check if the thresholds get a little better or they're still the same, and then maybe we can take the call.
Yeah.
To everyone, so Mansi, what is your protocol?
Yes.
Suppose you are amplifying the slide after diagnosis, there's this silence, severe profound, any kind of hearing loss, then you are going for amplification with a hearing aid. What is the protocol you do this aided responses? Do you see aided responses? At what protocol? Each day, after 1 month, because you are doing this aided response in with 2 months. So why in 2 months? Why? My question is,
so,
I'm providing a silent hearing aid for the junior colleague. This is for the juniors, huh? You are providing a hearing aid. So you are it's like a cross-checking your hearing aid things. It's amplifying or not, properly working or not, in a simpler way. That what is your protocol? How will you do this, all this audiogram and all this?
So see, there is no definite period given to us anywhere that you have to do the aided audiogram after a month or 2 months, but definitely within 3 months we need to have the aided scores with us.
Why you did this case here 2 months? Then?
Yes, that is what I'm coming to that. See, to get the aided thresholds, we need to condition the child. The child has to, when we give a particular stimulus, the child has to respond. And on the basis of that, so even when I did the unaided threshold, if we see this, the previous slide, the condition auditory was also done after 2 months. The rehabilitation program started with the BERA and the OE and the impedance measurements. We could obtain this course. We could obtain this course from this particular child only after 2 months of therapy and conditioning.
Mansi, very basic, huh? Please explain me what is the difference between condition audiometry and what is the aided audiometry.
Okay.
It's for the juniors.
Okay. So even the aided audiometry scores that we have obtained are conditioned responses. So here, if we look at this slide, the first picture that we see here is the BERA graph. The second graph that we see is, these are unaided. These are the thresholds. These are obtained through pure tone audiometry without any amplification devices. So these are the two thresholds of the child. BERA gives us an overall idea about the degree of hearing loss. Here we get frequency specific responses, and this graph that we see here is obtained after the child while the child was using hearing aids, and we obtained this thresholds via free field, not through headphones.
Okay, but your SILE is at 3 years that you did the audiometry.
So all of these are conditioned play audiometry. All of these will come under conditioned play audiometry. The one she did without the hearing aids, that is also a part of conditioned play audiometry.
Conditioned.
And only difference between the two graphs is the one which is the one without the hearing aids, the one which was done as part of the diagnostic procedure, that was under headphones, and the aided audiometry is done using free field. So that is the only difference in terms of the test setup, but the test methodology for both is conditioned play audiometry. So it's kind of the methodology that we refer to.
Yeah, thanks, Pagya. But how will you know that you did the aided audiogram with a bass amplification? That means with a bass hearing aid for very specific with this side.
So we I would talk from my point of view. When we are programming the hearing aid, we definitely there are set program parameters which are set depending on the age and acoustics and all of that, and then it is mainly the gain of the hearing aid that we manipulate, And typically we aim to start at 100% gain. For some children with lesser degree, like in this case, we may not go for 100% gain or 100% amplification at the start. We may start slow, and then that is why it is important to get the aided responses as early as possible, so that within the 3 months of time itself we have a window to optimize our programming, in case it requires optimization, in case we require to increase the amplification, change our programming in any way, or change the device itself. Then we have the time to do it, and that is the reason why we need to get the aided responses as early as possible. But when we say as early as possible, we have to be mindful that the child is conditioned enough to give us appropriate responses. If the child is not conditioned, if we just rush the testing, then it may be counterproductive. It may mislead us. So I think that goes back to your previous question, that at what time do we prefer to do aided audiometry? We prefer to do it as early as possible. For adults, in fact, we do a aided testing before fitting the hearing aid itself. But for children, since that is difficult, we have to do it after some period of therapy and training, and that's why we aim to do it as early as possible.
That means
so this aided audiogram, this was done when the gain was set at 90%. So after that, I'm planning to do another audiogram to see if there's any change when the gain is put at 100%. Yes, Visada, you can go ahead.
That means suppose you have a child who is wearing a hearing aid for the last 2 years, but it is not a based of, according to you, suppose they have reached your clinic, but according to you, it is not based of his amplification, then you will not going to do any aided responses with that hearing aid.
We'll have to see, Visada, how many programming sessions have been done with that child. See, we also have a lot of, so here the question is whether the hearing aid was programmed optimally, whether he was undergoing any therapy sessions or not, or just the hearing aid was dispensed and then there was no habilitation happening. That also will have to take into consideration.
And to know that the hearing aid, if we are saying that this hearing aid is not optimal or this programming is not optimal, to say that we need to get an aided audiogram.
Yes.
So that is the basis of confirming that yes, the hearing aid is not appropriate, or the programming is not appropriate, or amplification is not enough, the hearing aid is not enough, or whatever decision we take.
Okay, thank you.
There is one more question in the chat box, Mansi.
Yes, ma'am. Can you please read out the question, ma'am, because I'm in the slide share mode.
Okay, I will. I don't know who has asked.
You can stop sharing. You can stop sharing.
Prelingual adult word recognition score. Prelingual adult word recognition score.
I think they mean what is the criteria in terms of speech recognition score? What is the candidacy criteria for a prelingual adult? I think that is the question.
Yeah. So
for prelingual adult, we typically do not expect, especially in the auditory mode, we do not expect them to have much speech recognition. There is no separate criteria mentioned. Again, there's no separate criteria mentioned for prelingual adults in terms of speech recognition score. Overall, for adults, a speech recognition score of less than 60% in the better hearing ear is considered as a cochlear implant candidate. But if we think about it, for a prelingual adult, even obtaining a 60% score is doubtful.
Difficult.
Yeah.
Yes. When to use cochlear implant in one side and hearing aid in the other side. So just like the case that we just discussed, if we see that in 1 year, the aided thresholds are are within the speech banana, but not at the upper string of the speech banana. Can I start sharing the screen again so that? Yeah. So if we look at this audiograms, if the aided thresholds are somewhere here in one year, and then in the other year it is somewhere here. So in this case, when the thresholds are at the upper speech spectrum, then this individual is gaining access to all the speech sounds. So in such a condition or situation, the individual does not need a cochlear implantation. But in cases where the aided thresholds are still here, where the child or an individual is still missing out on a lot of speech sounds, so this can be, and then at the high frequency, the aided responses are outside the speech spectrum. In such conditions, we can think of going ahead with a cochlear implantation. I hope that answers the question.
Can we not assess the, hello, ma'am?
Yes, sir. Yes, sir.
Can we not assess the dead regions in the cochlea? How to do that?
So that is when we do the Puritan audiometry.
Right.
There itself, at any frequency, if the threshold is above 70 dB, that is an indication of a dead region.
Okay, I understand. That means be it BOA, be it PERA, whatever, maybe if the hearing threshold is more than 70, then we consider it as a dead region for that frequency. Am I correct?
Yes, sir. Yes, sir.
Achha, now as we have seen in this case, in this second case, I think this is the second case. This higher frequency, it is out of the speech banana. So this case, because for the speech development, I think cochlear implant will help. But where
yes,
the
sir.
other ear is almost okay. We need not use the cochlear implant on the other ear.
Yes, sir. So even if we have to implant this child, we'll be definitely going for the right ear. And in the left ear, we can still continue with the hearing aids.
Now, as we have cross hearing aid, where from one ear it suffers on both sides, for cochlear implant, instead of using cochlear implant, shall I have to use the hearing aid on the other ear also? Because because hearing aid is process is a bilateral, isn't it? Cochlear implant, though it will stimulate on one side, in the higher way it will go to the other side also.
Sir, the rationale used in the cross hearing aid is that cross hearing aid is used in individuals where there is a hearing loss, almost a profound hearing loss in the other ear, and a normal hearing on the other side.
Correct.
So
here in this case, as I can see jolly well, this is within speech banana. Of course, this is conditional hearing aid and all. But then why not use that one? We will the other ear also.
So I'm not getting your question actually.
No. The question is on one side, suppose with audiovisual therapy, say 3 months, 6 months, it has improved. It has come within the speech banana on one side. The other side is having some amount of outside speech banana. If we can use on that side where it is normal, the cross hearing aid, then it will go to the other side also. It will help.
Yes, sir, but for the cross hearing aid,
the child is already using a hearing aid on both the sides. No? So cross hearing aid, so you have to, if the one ear is normal or a high frequency hearing loss and one ear is profound hearing loss, then only you can use a cross hearing aid. In this condition, both the ear has hearing loss. But after with hearing aid, the left ear is showing that the speech perception is in the speech banana range.
Yes.
So there is no question of cross hearing it here. Because they already
not necessary, because already hearing aid they are using already.
The question of cross hearing doesn't arise at all.
So we can think of a cross hearing aid in this case. in this case, when an individual has this kind of an audiological profile, but in this child, we cannot use a cross hearing aid, because in cross hearing aid, you need to wear 2 devices. And this child already has a history of a global developmental delay and poor attention and eye contact. So it is very difficult for the child to retain 2 hearing aids in this case. We were even thinking of going ahead with a Baha device for this child, but then Baha devices are very expensive. So we settled with a BTE for this child.
Yeah.
Yes, sir.
But Baha will help definitely, because Baha is supposed to help better than these other devices, isn't it?
Yes, sir. But then the price was an issue for the parents.
And sir,
For
cross hearing aid is not a choice for the children. It is basically for the adult
Adult,
who,
yes.
who sits in the meeting. He has to listen from all the directions and all. Cross hearing is their choice.
But Bishar Bhai, Baha will help in this type of cases also.
Yeah, Baha will help. Definitely Baha will help. But Baha has a disadvantage also. If it is a child, if you put a Baha, if there is a fall, then there will be a head injury to the child.
I understand.
So Baha has advantage, but disadvantage also is there.
Yeah, granulation can happen, etc.
Yes. And Baha is a multiple stage surgery,
Second 2 stage.
Yeah.
Correct.
Not currently.
Not the surgical Baha, the hearing aid, the soft pants.
Yeah.
Not with the current devices, and with the current devices, like even Baha, like earlier Baha devices had to be fixed transcutaneously with the internal component, but these days there is percutaneous coupling is also possible. So all that is there. But having said that, even be it cross hearing aids or be it Baha, in both of those conditions, it's not the true binaural hearing that the patient. Ultimately, both of the devices are helping collect the sound from the ear with hearing loss and providing it to the better cochlea. So all of the binaural functions like binaural integration, interaction, understanding speech and noise, those are not really getting much help from any of these devices. But yes, both of these devices will help them pick up sounds that they would otherwise be missing out on the side that they have hearing loss. And yes, to some extent, understanding will be better in noise because they have enough hearing from the other side also.
Correct.
So Mukherjee sir, these are the cases as per guys says for if the binaural hearing. This is the expanded criteria for CI. But most important is that why he has a unilateral severe to profound hearing loss. That should be evaluated. I think we have a next question by Phukan sir. So radiology is must. So at least you do going for any kind of intervention, at least you do MRI, have a look the integrity of the cochlear anatomy and also the nerve
also.
So he may be a candidate of absent nerve on unilateral side, or he have some issue with the anatomy of the cochlea on that side. So, but otherwise, if it is all things are there, so this is the expanded criteria of what Mansi's topic is today. So it is approved by FDA also in 2019, but we have a no experience till date. But single-sided deafness, this kind of situation is now the expanded criteria.
Bishwa, did you perform a surgery on single-sided deafness?
No, sir. So this is a lot of discussion is going on. Many people don't believe in this. Sumit Meg in Delhi, actually, he is doing mostly in highest in I think according to my knowledge in India. But many people has a criticism on the single-sided CI still in India. It is not popular in India.
But it is popular in Europe. No, Europe they do it.
Yes, sir. Yes, sir. Yes, sir.
Insurance, I think everything gets covered by insurance.
Definitely.
There are three questions asked by Dr. S.B. Fukan, sir. I'll read out, okay?
Yes, ma'am, please.
When to use CI in one-sided hearing aid and in the other? When you can and when to use CI.
Ma'am, we have answered this question.
Okay. And CT and MRI, which one is better for candidacy selection?
Both, I think, from my knowledge, I think both are important.
संसिता बोलो कुछ ऐसे बैठा क्यों है?
Both have different role. MRI is, as you said, it's for the integrity, looking for the integrity of the nerve and for the whether it's a fluid-filled labyrinth, whether there's any anomaly. And CT is also important because it gives us an idea about like a mapping about how to go about the surgery. It gives us a lot of information. So yeah, both are important, but looking for the integrity and cochlea, MRI is definitely better. That is required.
I think both are required. No,
Yes, sir. Yes, sir. Both are required. Both are important.
So
both have different.
Both are important. Suppose this is 2 years, 3 months child. They are not interested for any kind of CI kind of thing. Then what is the if you advise any radiology tomorrow, it is always a MRI. Not
right.
It always a MRI, not the CT.
And for a sequential implantee, of course, we try to avoid MRI. And if at all required, we go for the CT.
That's why, that means before putting any hearing, any intervention like hearing aid or cochlear implant, the protocol should be, you should go the radiology first, particularly in case of severe to profound hearing loss. Suppose you are getting responses, it's moderate because you are already getting the responses. Definitely it doesn't require the radiological intervention in pre-front. But if there's a profound hearing loss, it's always better to go for radiology first, then go for the intervention like hearing aid.
So another question by Fukan, sir. Any special CI for post-meningitis cochlea?
Sclerosis, fibrosis, and ossification.
Any special CI for post-meningitis cochlea? Any special CI means?
Are you talking about electrode or what?
Electrode. So it depends upon the radiology. I don't know how many this. That's a great rule of MRI actually. The MRI can differentiate between the fibrosis and ossifications. So and nowadays the depth gas is also coming with a depth gas means how much depth you can insert the electrode. That thing's also coming with a specific company like Cochlea also. So they always provide a depth gas with the electrode. How much electrode we can introduce in the inside the cochlea. But more than that, more practically, most of the people, the baseline is the MRI study. What is the according to them and what is the terms involved? Is they go with a electrode. There's no kind of a special electrode for meningitis cochlea. That's
the best if we can pick it up quite early.
This is the only emergency condition for cochlear implant. This is one of the, there's a 3 emergency condition. This is one of the emergent condition of cochlear implant.
They say like even if we can't put an electrode because of economic reasons, then we have to put something inside the cochlea just to maintain the patency.
That's the only paper by Kitten is
to avoid oxidation.
Yeah, you can place a stent.
Yes, almost like stent.
So Mukherjee sir, the intention of today's topic is that before going for any electrode implant, electrode insertion, the test required is your aided response. That's the most important test. That's why we are putting this topic today actually. Biswas sir, am I right? Am I right? So that's why we are putting, because if you see all the criteria, it is not on the basis of the autoacoustic emission, BERA, all these things. Yeah, background is all these tests are there, all test batteries are there. But if you see, ultimately the eligibility criteria is depends upon on the aided response. So that means we are doing cochlear implant who is not responding to hearing aid. The line is like that, not responding to the hearing aid. So how will you know that this child is not responding to the hearing aid? What is the test? This was a classic sentence during we have learned from our PG days. But how will you know that it's not responding to the hearing aid? I got the experience, I got the knowledge after 5 years of doing PG. Sorry to say, sir, that I know that this is a test that we have to do the aided response with marks. Am I right, sir?
Yes.
Vishwa, sir? Suppose in a clinical scenario, if child is coming with a hearing aid, only one year, and he has a diagnosed child of severe to profound in the both DA. How will you do the aided response then?
Sir, what? Can you please repeat the question?
Suppose somebody referred a case to you. He is now 4 years child and he is using hearing aid only 1 year. Previous diagnosis was a bilateral severe to profound hearing loss. Now, today you have to do the test aided response. Now, how will you do this? His aided response.
See,
only one hearing. If he has only one hearing aid now.
So first of all, while we just to give a little information. So when we do the aided audiometry also, what we do is we put, suppose if I'm testing the aided thresholds for the right ear, I put on the right hearing aid and I try to occlude the other ear with the ear mold of the neck.
Occlude means don't take the occlude. That means you are doing masking.
Yeah, because we don't want responses from the other ear.
No. You are occluding you are occluding or masking.
Basically masking.
Yeah, basically.
Don't say occluding then. You are doing masking. Okay. Then.
So that is how we find out the aided thresholds for the right ear and the left ear. Now, the case that you mentioned that the child has been using the hearing aid only in 1 year. So we'll have to again find out, even if the child is 4 years of age, we have to find out whether the child is conditioned to respond to the thresholds.
Suppose he is a condition. Then
maybe in the year where he has been using the hearing aid, will, even if the degree on the type of the hearing aid both here is similar, but he has been using the hearing aid on the right ear. So maybe we can expect better thresholds in the right ear than the year in which he was not using the hearing aid. Because there has been no stimulation. If he's not using a hearing aid, even if he has been getting at least 10 or 20% of stimulation in the year where he was using the hearing aid, the other year he's not getting any kind of stimulation.
Because he's not using hearing aid on that side.
So how will you do the test?
So we'll have
the reporting.
So we'll have to
when you report that year.
So if we have to find out the thresholds in that year, we'll have to make the child wear the hearing aid in the other year also, and then get the condition responses out of it. We cannot expect it in the single session for the other year, for the year where he is not using the hearing aid.
So you will call this child again.
So may I interrupt? So if you're saying it's a severe to profound hearing loss case, bilateral severe to profound hearing loss, and he's using a hearing aid on the other side, we want to see the responses for the side where he is using hearing aid. So we don't need to do masking for this child because he has severe to profound hearing loss on that side, and we are presenting sounds on the side where he's wearing hearing aid. We are presenting sounds at a lower level. We are expecting responses at a lower level. So the side which has profound hearing loss is not going to be able to participate or not going to be able to respond to that level of sound. So in such case, we don't really need to mask that ear.
Other ear.
We don't really need to mask the other ear because that ear already has severe to profound hearing loss. It is not able to hear sounds at 80 dB, 90 dB. If the side where he is wearing hearing aid he's not able to hear sounds at 80 or 90 dB, that means he's not getting any benefit at all with that.
No, his question is again, what about the thresholds in the year where he's not wearing a hearing aid? How do you get the responses? The second part of the question.
Condition we get. So
yeah.
What response are we? What are we expecting? Are we talking about aided responses or
aided responses?
Aided response.
aided response for the side where he's not been using hearing aid.
Yes, yes.
Doesn't matter. If he's conditioned, it doesn't matter. If the child is conditioned, he will respond to the sound, whether it is coming from the right ear or left ear, whether it is coming from the side where he's been using hearing aid or not using hearing aid. But like Mansi said, his responses on the side where he's been used to using a hearing aid will be better than the side where he is, wearing the hearing aid only for that session. But I think what sir wanted to know is, the methodology, how we will check the response only for 1 year, where if he's using the complication comes in asymmetrical hearing loss, like the second case or even the first case that Mansi had presented, where it's not a severe to profound hearing loss. There is asymmetrical hearing loss, or there is some amount of residual hearing in both the ears, maybe severe loss or moderately severe loss. 1 year is better than the other. So in those cases, we need to ensure that while we are doing the aided response, getting aided responses for 1 year, we are masking the contralateral ear. Did I make it clear, or did I make it more complicated?
It is getting
No,
complicated.
what I understood from the question is, Pragya, sir is asking, the child was not wearing hearing aid in the left ear, suppose. So he has come for the test, aided audiogram, and you have to do the reporting. So on the ear that he's not using, will you like make a mold, like impromptu, and then use a hearing aid which you have at hand, or will you call the patient later?
We have to call. We cannot make a mold impromptu.
So the complete aided audiogram will be done only like after calling the child for a second time, probably, right?
At least for the year where he doesn't have a hearing aid, or he doesn't have a mold.
Yeah.
Okay,
there are more questions from Fukon, sir. Residual hearing is damaged by more insertion of electrode. Why there is different length of insertion in different city electrode?
Mr. Da, will you take up that question?
To look the because I know this is a question for the surgeons, but you should also have the capacity to reply. Please try. I know, but Sari is asking why there is a different length of insertion in different
company.
Maybe company or different length.
First question, is residual hearing damaged by more insertion of electrode? By longer electrode, is residual hearing damaged? First question.
Mansi?
See, there are now even the literature, certain literature, they say that if you try inserting an electrode which has a complete coverage, it leads to residual hearing damage. And moreover, see, the idea is to get not to cover the whole cochlear length, but the idea is to get the maximum stimulation out of the cochlear implant. So if we see the spiral ganglion cells, see, Medal has a rationale that if you cover the whole length of the cochlea, it will cover the whole frequency range. But there are other companies like Cochlear and Advanced Bionics, which say that the the spiral ganglion cells
up to the epiphysis, yes.
Yes. So this is where companies differ in their view towards the electrode lengths. But again, in today's with today's technology, advanced technology, there are more perimodular electrodes coming.
Yes.
The rationale behind this electrodes is not to cause damage to the residual hearing, and more focused stimulation with lesser amount of current. So.
Yeah.
So to answer Pukansa's question, yes, I think deeper insertion will, if there is residual hearing, deeper insertion will damage residual hearing. Introducing an electrode, a foreign body into the cochlea, it will disturb the entire of the fluid environment, the electrolyte balance, everything, and that will definitely have an effect on the surviving cells and tissues.
Moreover, diameter is less in the epiphysis.
Correct. So chances of physical damage is also high. And different, I think that is the whole rationale, like Mansi also explained. Different companies believe like some companies believe that there are not enough spiral ganglion cells in the apical region, so it's not really it doesn't really give that much advantage of deeper to insert very deep. Whereas even for those, even in cochlear, there are electrodes where in their slimmer electrodes, they have this rationale that if a person has there are different markings. So if a person has more residual hearing, the electrode insertion is limited to a shorter length, whereas if there is no residual hearing, then the electrode can be inserted deeper. I think with their current slim straight electrode also. So I think
Medal's rationale is about music perception, no?
No.
Yeah, they believe that the low Medal believes that stimulating the apical regions are also important, and low frequencies are important for especially for music perception, rhythm perception, suprasegmental perception. And Medal also believes that there are different individuals have different cochlear duct length, and based on that they have
an auto plan.
Yes, based on the auto plan.
So coming to in context to the today's topic, as Mansi says that this child has a residual hearing, so definitely we'll go with a shorter electrode, not go to a long electrode. Better less than 19 millimeter, the standard cochlear electrode. Definitely choose a shorter electrode, but it is not the length of the electrode. If you have a very good residual hearing, I'm telling from the surgeon perspective, sir. Okay, sir, I'm telling sir, it is not the length of the electrode. It's also the how you have inserted the electrode. That's also important. What is the diameter of the electrode? That is also important. Both the apical and proximal diameter. And another important thing, that what is your approach? So if you see, if you have a residual hearing, better to go with non-cochleostomy approach. That means you go with a more soft approach. There's a round window approach. So all these things algorithm give a good residual preserve till date, along with installation of intercochlear steroid. That also we will give every CI intercochlear electrode. But if you have a residual hearing, good residual hearing, so that's why the new electrodes are coming. Already we have, I don't know, I have no experience. Drug eluting electrodes. So these are the electrodes. They try to regenerate the hair cells. They try to preserve the residual hair cells inside the cochlea. So these are the things research is going on to preserve. That's why you have now the surgeons are in a tricky position. That means audiologist is taking, sir, this is a residual hearing of this child. The parents wants to give a better speech outcome, and you have to do the surgery. Now you have to see all these factors to preserve his residual hearing. That's a take.
Can we also, in cases of residual hearing, good residual hearing, can we also explore the EAS, the electric acoustic stimulation? Because we do have electrodes available.
Yes. Electroacoustic stimulation will sell the integrity of the hair cells, the residual hair cells. Correct, you are. That is one point. Now, what I was thinking, Vishwajit, the mid-scalar insertion instead of lateral hanging or modular hanging, where the chance of damage to the basilar membrane. Mid-scalar incision is, and that too, you have rightly told, going through the round window itself. That is the right way to preserve the hearing. Am I correct?
Yeah, sure. Definitely.
I think the points that Vishwajit has mentioned is basically true for whether you have a detectable residual hearing or not. I think that soft insertion and all those points that you have mentioned is important for all insertions, isn't it?
Correct.
Yes, sir. It's important for all insertions because it's not exact 1 + 1 is equal to this much of residual hearing is with this recipient. So we should do for every candidate. That's why you should exercise for it. But you should be very careful if you have a good amount of residual hearing. That's the thing.
Therefore, if the child is not improved as expected, then blame should go for the surgeons and the ABT trainer also, both.
Exactly, sir. it's like a otosclerosis surgery. That's why I
Yes.
think otosclerosis surgery is more challenging than cochlear implant.
Yes.
Because you can't give a dead ear. Suppose
Yes.
residual hearing is like a not a dead ear kind of thing.
Yes.
It's a near dead kind of thing. So you can't give a dead ear with a residual hearing. That's the expanded criteria. What Mansi has said to me, actually, sir. That's why you have to do. I don't know how many people in our part have do the base editor responses, because this is the report we have to send in a diff scheme also. This is the report we have to analysis before the, because I asked my all audiology colleague that which year I am going to do.
Yes.
That's also important. Suppose you have a in OE and BERA report, BERA basically, you have a bilateral severe to profound hearing loss.
Yes.
Then both years, any year you can go. But it is ultimately the added response. They guide us that, sir, you go with the right ear, you go with the left ear. Am I wrong, Pooja?
Yes, sir. Not wrong, sir. Right.
But Biswajit, once I've told you, the Manish Grover from Jaipur, he told that this is the evolving type, the electrode insertion, ABT training, candidacy selections, all are most important. And he told that the child will blame in the letter that how much damage in the cochlea we have done by inserting the electrode. You also do not know, and myself also don't know.
Exactly, sir.
That is the main thing I have told you. He has nicely explained about these things.
Exactly.
From Manish Grover.
Correct.
So if you have everything, but your microscope is not that enough magnification, not enough resolution, you don't know where you have how much force you have inserted, what is the mark. They have a definite mark is there, so that they don't do injury to the inner environment of the cochlea. But if you have not seen, you are just pushing the electrode. But no meaning of talking on all this residual hearing, actually, sir. Say, there's a hole and you are inserting wire. So if it is the only principle, then we should not talk about all
that
this.
That was shown by Satish Jain with a C-arm, with your silo endoscope to insert in the cochlea.
Yes.
And to how it goes like that. That is one during the workshop. I remember that.
Yes,
But
sir.
I want to ask a question. Is there any criteria or a guideline that aided audiogram should be always do, as Vishwajit has storytelling? You should always do. Is there any criteria or guideline in all cases of
that was my first question, sir.
Yes.
And that was the criteria for all category, no? Even
yes.
Everybody is this criteria. Edit social, edit response.
Right.
So I remember attending on World Hearing Day, there was a talk by Dr. Manoj Manikot. Like there, they are advocating this, that nowadays the gold standard is aided audiogram, not BERA.
Exactly. But sir, Biswas sir, I generally very simple thing. I'm just quoting here. I have taking photograph of one of the bilateral implantee from Mohan sir. How they are doing all the investigation. He's a bilateral implantee. Recently is coming with some issue. Okay, that's a different topic. But I have seen the report of the added response. It is Mansi. It is not like it is they have in your report card. They have only umbrella. They have the Poiga must probably have. They have all the what the hearing aid they are using in the right ear, what the hearing aid they are in the left ear, what is the duration. Are you getting my point?
Yeah.
So everything is written here.
Yeah, actually, we also have in the report, we write it down, but because I did not want to advocate the company, I did not want to advocate any company, so I did not write the name of the
But that is your philosophy, but I don't know, because that's where, because suppose a counts a word here, the Zwisla Bacchus. If somebody has a Zwisla Bacchus, that means this not programmable hearing aid. Then you are doing added response. How will you know that you are doing added response? Somebody is doing added response with this. Hari?
So, Biswada, what I'm saying is, in our reports, when we send the report, in our reports, we write down the name of the hearing aid, the company, everything. But today on the slides, I did not mention because
today, exactly. I'm not taking today's presentation.
but otherwise we mention. Yes, we in our report we do mention.
I have seen there are two reports. I have seen there one aided response with a hearing aid. I have with a copy of the aided response with a cochlear implant also. So both the things they have mentioned the equipments. I think that should be mentioned. It is not the company thing. It is the way that what is the amplification device they are using actually.
Yeah, we do mention. We do mention both for.
Yeah.
We do mention for hearing aid cochlear implants also.
In case we use different gain settings or something, that is also mentioned. But if we are using only a particular maximum gain setting, then we don't mention that in the audiogram. But yeah, I guess that mentioning that will also be helpful for the future.
Biswas, am I wrong, sir, again?
No. There is no harm because you are using a hearing aid. The next person should know what you are using. What hearing aid you are using.
Your amplification is proper, and with that amplification, these responses are proper or not.
Yeah.
That way, you can say he is a candidate for CI.
Yes.
I have a question, Biswajit. If there is a 1.5 tons cochlea, we have a patient, 1.5 tons cochlea. We are planning for an implant. Is it possible?
1.5 ton cochlea is there. So actually, you have to tell the what is the anomaly then. Look, 1.5 ton cochlea. I forget the anomaly. Because definitely if the other things are okay, then definitely you can go for
short electrode.
But issue is that, so that's why I'm telling I'm very basic things today.
Plugging and all.
No. These are the problem with us. It is not the 1.5 ton of the cochlea. What is our diagnosis? That's the most important. How do I do your diagnosis, sir? This is not the Biswas. It is I should write the diagnosis. What is my diagnosis? You have to classify the diagnosis as the present anomaly scenario. We have a scenario classification. We have a Indian classification. Forget about the Indian classification. At least you have a 2 classification. At least we have the scenario classification. Then what is the 1.5 ton of cochlea? So we have to classify that patient accordingly. And definitely you can go if the other things are okay, then we can go for cochlear implant. It's not as I think, but you have to go with a short electrode. Medal is a short electrode, 12 mm electrode.
The cost doesn't differ, same electrode cost doesn't differ.
No. They have this is actually, sir, what happens? That's why you send the DICOM image to them. You send the DICOM image to medal people. They customize your electrode length.
Right.
You send the DICOM image to them, and they will customize your this length. Then accordingly, they will send you. This is the same price. The 12 mm. So price will be same. Sorry, you send just the DICOM image.
I think it's Mondini.
Mondini
deformity.
No.
1.5 tons is not Mondini.
You can't say.
Because partitioning is not there, no? 1.5 ton. That's it.
No. 1.5 ton is not a Mondini. Because I have to get, because I forget every time. I don't know. It's a very tough classification. So I'll check and I'll let you know. I'll send a scenario paper.
Right.
Okay, I'll send a scenario paper and just check once.
Incomplete partition type 2.
But it is the duty of the radiologist also. That's why if you, I should not the code of the name of the center. If I send the center, they always read and then accordingly they give the reports. Actually, they don't only the code.
Mrs. just asked whether there is an enlarged vestibular aqueduct also along with that.
Because if you have all these syndromes, then other features also be there that we have to look at. Okay, thank you, sir. That's enough, I think, for 10 o'clock now.
Sorry to interrupt you. Very interesting one, but we have to end it today. Okay.
Okay, ma'am.
Thank you. I just a minute. I'll just
But very
I-
nice presentation by Manashi.
Yeah, very nice present. Sorry,
Very
more-
And moreover, slides are very good.
Thank
Yeah,
you, sir.
very informative, Manshi.
Simple and short,
Very
and in right time she has finished. That is most important present scenario.
Thank you,
yes,
sir.
very
Thank you.
interesting cases also she has taken.